Thank you for the kind introduction. So today, I'll talk. Well, yesterday I talked as purely as a radiation oncologist. Today I'll talk about a radiation oncologist also being a hepatologist also. So these are my COIs. Okay, so HCC is a quite common disease here in mostly in East and Southeast Asia. This generally overlaps with the occurrence of HB, but that is subject to change because of all the antiviral drugs and the emerging of MASH muscle. So we all know about the risk factors, so I'll just skim through. But so we are seeing less Hep B, Hep C related HCCs, and now more increasing MASH derived HCCs. So I'll just so the thing is that the NCC and treatment guidelines for HCCs, there is minimal mention of radiotherapy. This is also so in the BCLC guidelines, and yes, it has been updated. I think it was 3 days ago or 4 days ago. Yeah. But yes, it still lacks the mention of radiotherapy. It has, if you read into the actual article itself, it does mention about radiotherapy, SBRT, and a little bit about protons, but there is no mention in the flowchart itself. So, well, it's just minimal. Okay, so, but actually, there's a lot. If you've been treating HCCs, there's a lot of gaps within these flowcharts. Yes, it has been described very detailed, but there are gaps between these lines. So let me present you a little case. 85-year-old female, hepatitis B, under NA, with a Child-Pugh score of 5A. Primary, solitary, 2.5 centimeters, no MBIs, and a modest elevation of AFP of 40 nanogram per milliliters. What would your first choice be? Let me present you another case. A 65-year-old male with MASH LC, Child-Pugh score 6A with a modified LB score of 2B. Primary, solitary, 7 centimeters in diameter, S8, partly S5, S7. No MBIs, and again, a modest elevation of a P of 150. What would your selection be? Okay, so the issues with the current guidelines is, well, extensively categorized. Gaps in the system are significant. American and European guidelines lean towards transplantation where it may not be feasible in Asia, and minimal description regarding radiotherapy. So the most survival affecting factor, apart from tumor control, is the liver function, and, well, the remnant liver function. HCC is a recurring disease. Liver cirrhosis itself is a strong risk factor of HCC. So it is essential to treat and manage HCCs without affecting liver function or the function reserve. And balance between tumor control and liver function is always the million-dollar question. So we have a couple of local regional therapy options. Of course, well, surgery being the golden standard, but Other than that will be RFA MWA, which has a very good local control, which emerged in the 1990s, and good liver function preservation and repeated treatment is possible, but is limited by size, and biliary toxicities will be an issue. TAE, TACE, ability to treat multiple lesions, very nice, but the issue is with the low tumor control rate and the liver toxicities. So if you repeat TACE, you will, the patient will suffer from low liver function. That's where radiotherapy comes in, SBRT and particle therapy. Actually, particle therapy for HCCs came before SBRT as the definitive radiotherapy option for HCCs. In the 1980s, a team from Japan wanted to treat HCCs with radiotherapy and came up with proton therapy. So good local control and ability to treat larger tumors, yes, and repeated treatment is also possible, but it does come with a high cost. Whereas with the SBRT, moderate cost and good local control, but limited by size. Anything over 5 centimeters could be very challenging. Liver function toxicities also lead to limited repeated treatment. So radiotherapy 101, effect and toxicity only occurs when it has been irradiated, and effect and toxicity is dependent on the absorbed dose. So this is a figure I like to use. This is obviously head and neck case with dermatitis, and you can, when the dose is superimposed, the high dose area will correspond to the severe dermatitis, whereas the low dose, not as much. So SBRT, high dose per fraction, higher efficacy, higher toxicities. So in most cases, when dose per fraction goes up, toxicity worsens before efficacy improves. So SBRT can only be realized with good patient positioning and internal motion addressing. So the key factors in radiotherapy for HCCs are large and complex internal motion due to respiration, OARs, especially the GI tract, and the target being within a very low tolerance dose parallel organ, which is the liver itself. And you have to consider repeated treatment. So with SBRT, while lacking level 1 evidence, real-world data shows significant improvement over TACE and possibly RFA also. Definitely a viable option when surgery nor RFA ablation is not an option. And the literature says 3 to 5% radiation-induced liver damage, and I'm quite skeptical about that. And most of the literature do not distinguish between classical RILD and non-classical RILD. Classical RILD is the actual, the one you can't save. And the non-classical RILD is, well, that's just radiation hepatitis. So long story short, your plan sucked. So the actual toxicity itself is probably a little bit more mild. Okay, so back to the first case. So this one, not such a good candidate for ablation therapy because of the proximity to the bile duct. Surgery, if you want to resect this 85-year-old female, yeah, well, knock yourself out, but maybe not the best option. So in cases like this, well, SBRT is a good option. So re-irradiation, you will have to do re-irradiation to the liver. Not necessarily to the same tumor, but a recurring new lesion. So can re-irradiation be an option? So the issues here will be, can the liver tolerate another course of radiotherapy? Or can the OARs, other than the liver, tolerate another course of radiotherapy? So sadly, we don't have any prospective studies regarding this. There are a few retrospective studies implying safe treatment. They show same local control, same liver toxicity, and spare liver volume MLD B20 didn't show to be a risk factor of overall survival. The caveat of this study was the small tumor size with median diameter of just under 2 centimeters. So large and complex internal motion, well, is addressed. OAR, especially the GI tract, can be also addressed. Target within a low tolerance dose parallel organ can be an issue, especially in large and/or centrally located tumors. And repeated treatment could be an issue. And that is where particle therapy comes in. So when we're talking about particle therapy, we're talking about carbon ions and hydrogen ions. So what's so special about, well, not just carbon ion, but particle therapy in general, is that we have the Bragg peak, which enables us to produce a distinguished dose distribution. Now, the higher biological effect of carbon ion is not so relevant when we're talking about HCCs. So it's just pure dose distribution. So with SBRT, you can see the 50% isodose line here, whereas with particle therapy, it's very confined to the tumor, and also the 30% line also. So you get like about 40% to 50% decrease in the, especially the 20 gray to 30 gray area, which actually means the most. Okay, the only issue with particle therapy is the huge size. This is a this is the carbon ion accelerator we have in my facility, QSD. 60 meters by 120 meters, so yeah, about 2 tennis courts. Proton machine also a little bit smaller, because the diameter here is about 13 meters, but so a little bit smaller, but still very large. The treatment room, and yes, of course, respiratory motion management is also a very key factor of this technology. So how are the outcomes? So particle therapy, comparable with SBRT in smaller tumors and better than SBRT in larger tumors. We actually did a meta-analysis and comparing SBRT and particle therapy. I'm really sorry I cannot show you the actual figures because it has not been accepted yet. But it should be available within the next few months. Also, repeated treatment also being reported to be safe and great option for larger tumors, decompensated liver function, and tumors with MDIs. The toxicity minimal with up to 1% RILD and GI hemorrhage. So looking back at the second case, well treated with proton. This is passive proton, so you get a higher dose here, but still. So even like tumors like this can be treated with carbon ion, even with decompensated liver function. Okay, here's another case with a tumor here. I treated this like this, but this dose distribution, this treatment plan has a critical flaw here, and it's the dose to the stomach. Had a very high dose to the stomach, about D2cc of 24 gray in 2 fractions. So after 1 month, we see this sort of redness here. Gets better at 3 months, but you can see a very narrow but very deep ulceration at 6 months. Now, if you see this with after any treatment, say cervical cancer treatment, you're expecting a huge ulceration. But with particle therapy, there's no dose around here, so it gets better. So I think, yeah, we're running out of time. So, okay, so particle therapy for advanced ACCs and MBIs. So reported overall survival is 26 to 40 months. So ICI is reporting 8 to 10 months, so that's something quite substantial. Minimal toxicity, including hepatic function, but the low progression-free survival is an issue. So there are a lot of trials going on with radiotherapy plus ICIs. Okay. Also, reiteration for ACCs with particles can be done with second radiotherapy, same local control and same, well, no liver toxicity. So, yeah, I think we could just skip this. So, in summary, radiotherapy offers definitive treatment opportunities for those who are not eligible for resection or RFA-MWA. Good efficacy over 90% local control in 3 years with limited toxicities, even for the clinically unfit. Conservation of unirradiated liver and keeping liver dose as low as reasonably possible is crucial. And re-irradiation is possible, though careful consideration to the liver dose is important. Particle therapy can well treat tumors over 5 centimeters where SBRT is not an option. So that's about it for me. Thank you.